HCV2 treatment with direct-acting antiviral DAAs for cirrhotic patients with or without HCC, chaired by Dr. Wei and Dr. Kanto.
Okay, good afternoon, everybody. We're going to start the session as informed. Treatment of HCV with DAA, with or without HCC. This is a really important topic we need to discuss. And today, in this session, my name is Tatsuya Kanto from Japan, and co-chair. Let me introduce Professor Wei Lai, and he's professor and next president of APASO in 2025, which is going to be held in Beijing, I believe. Yes. But anyway, the first, I want to announce that the order of the presentation is a little bit changed because of the housekeeping. And Professor Wei Lai is going to speak first, and which follows the second speaker. And I want to apologize for the change of the speaker. Okay, so Professor Wei.
Thanks, Professor Kanto, and thanks for your kind introduction. And once again, thanks for organizing committee kind invitation. Also, thanks to Professor Zhuang Wanlong for your kind and give me this opportunity because I have overlapped for a lot of talk. So I want to, so Dr. Kanto helped me, Dr. Zhuang Wanlong helped me to give a chance for to do the first talk. And today, my topic is the DAA treatment and hepatocellular carcinoma in chronic hepatitis C. And we already have the DAA for treatment. Unfortunately, still some patients develop to the HCC. And meanwhile, even in HCC patients, and they treat with the DAA and also the eliminated HCV RNA, then also the hepatocellular carcinoma will recurrence again. So therefore, it's an important topic. Maybe in the future, and it's more important and more important. So it's my disclosure. So if we do not intervention the patients, if we do not give the treatment, what's the natural history of HCV infection? And as well, you know, acute infection and last for more than 6 months will be and develop to chronic infections. It's dependent on the age and also gender. In children or in women, and the chronic rate is a little bit lower. And however, in older age or in men, maybe more patients develop the chronic infection. It's around totally is the 75 to 85% develop to the chronic infection. So also meanwhile, they will also have some extra and manifestation, including kidney and the skin, even and the heart and the cardiovascular and the organ and tissue. In chronic infections, some patients will develop to the cirrhosis, and it takes time, longer and compared with the HBV infection. Usually it's it take 20 years, even the 30 years. Even the patients develop to cirrhosis, and some patients will develop to the decompensate, and at 20 years, usually it accounts for 30%. And also, what is important, the topic today is the early instance in this kind of patients is hepatocellular carcinoma. Usually, and is estimated 1% to 4%. Also, some reports from Asia is up to 7%. So therefore, the HCC is developed in some HCC developed in some HCV infected populations. So here, and I want to show you a natural history study for the compensated HCC. So therefore, and we want to focus on the cirrhotic patients. This study took in the 17 years in the cohorts, and you can find here the annual rate is in the 3.9 for HCC development. And meanwhile, you can also find some other and decompensated complications, including ascites and jaundice and GI bleeding, or even hepatoencephalopathy. So therefore, among these complications, HCC is the highest incidence in HCV infected patients. I mean for the HCC cirrhotic patients. So if we give the patients, or if we not give the patients, how about the development for these patients? We can conclude here from some of the study, the liver complications due to the untreated chronic HCV infection continue increased. So because it's, and most of the people did not get screening, did not get a diagnosis, and did not have the treatment. So therefore, and we already know that maybe in some patients will develop to cirrhosis and some patients develop to HCC. And it is estimated by 2030, approximately in the 45% of untreated, and also HCV patients are projected to develop cirrhosis. So we have to take into consideration to increase the screening. Also, the patients who develop cirrhosis are a great risk for developing hepatocellular carcinoma and other complications. So in the United States, HCV is the leading cause currently of the liver transplant and also the liver cancer. So therefore, and you can find, if you did not have the very effective screening, very effective diagnosis, and a very effective treatment project, the HCC cirrhosis and HCV cirrhosis and the HCC will and more higher. And however, we do something to control HCV infections. So the incidence of HCV-related liver cancer or death is expected to peak in soon. So it means, and it will be going down in soon. So you can look at this picture, then you can find, if we treating more patients, the peak cases of liver disease and also in the transplant patients, and also the death will be going down. So therefore, we will take actions before the 2030 to get more patients screening, diagnosis, and treatment. Why treatment? And the previous data always show us association between the SVR and survival and outcome established. In this interferon-based and treatment data that you can find, if we get the patients the treatment, then the patients the outcome will get improvement. You look at these pictures, and the blue curve is the SVR, and the red curve is the without SVR. Then anyway, in all-cause mortality, liver-related events, and hepatocellular carcinoma and the liver failure will keep the low level is almost close to zero, and among the patients treated and get the SVR. So therefore, it's interferon data. So how about the DAA data on the mortality in patients with the advanced liver disease? Here you can find the red color indicates low SVR, the blue color indicates the patients get treatment effectively and achieving SVR. Then you can find once getting SVR, the mortality incidence of hepatocellular carcinoma, and as well as the mortality in patients with HCC pre-DA get a significant improvement. So therefore, and the DAA treatment is also effective to reduce the patients develop to the HCC. However, we still have some patients and have the de novo HCC development, even during HCV treatment. So therefore, you look at this data. This is the retrospective study in 167 medical centers, including and more than 35,000 interferon treatment, and also more and DAA plus interferon and more and the DAA only treatment. Then you can find here, if the no cirrhosis or patients achieve the SVR, the properly free and from HCC is very good. And however, and if the patients with the cirrhosis, even no SVR, the HCC development probability will be and show us is take and significant and change. So therefore, it means that we should give the patient treatment, no cirrhosis, or even for cirrhosis patients, we still have to get an SVR to reduce the risk of the HCC. So, however, we still have some patients and have the HCC and occurrence. Here, and I want to show you some other studies. In this prospective real-life observation multi-center cohort, totally and enrolled 2,214 consecutive DAA treated with the liver cirrhosis patients, then follow up and 30 months. So you can find in this population totally, and you have the characteristics is the baseline for liver stability is pretty high compared to the low HCC and occurring the patients. Also, and all we can find the other and clinical and parameters, such as you can find, and more patients have the FIB4 high risk with the 3.25, and also high percentages for CHAP CTPB and patients. Also has the other and the decompensated such as ascites and high percentages for the viruses. So therefore, it seems and the baseline and characteristics have very good high association with the HCC and occurrence and the lower development, even follow the HCV RNA and clearance. So we can also have some other data. Here, I want to show you the genotyping. It seems that genotyping 3 and have the high risk with the and other genotypings. And also, because age is also important and in fact, but the genotyping and decompensate and show and significant impact on this outcome. And also, you can find here in the during the treatment, if the liver stability and changed, and so the HCC will and in change for this and kind of the populations. So the instance of HCC is reduced in HCC patients FSVR. You can say that. And in this study, and you can find the patients with diagnosis of cirrhosis and the highest instance of HCC. HCC was also higher in those with alcohol use and the lower African America. So therefore, in addition to the baseline of and the cirrhosis and the fibrosis, the other impact and other confounder such as alcohol also have impact on the development of the HCC. So therefore, and we should also control other impact for that to reduce the HCC development. And therefore, and in addition to this study, most study and show us the patients no cirrhosis at the baseline. SVR achieving is the key point for HCC development. Here is another study that indicate SVR is the predictor and of the lower HCC development. Meanwhile, it's also is predictor for recurrent HCC development. In this study, is a multi-center prospective cohort, including 1,900 HCV-infected cirrhotic patients. The study and conducted in Italy. Then you can find both in de novo HCC, also HCV recurrent. Then you can find SVR enhanced and also the low SVR have the significant differences. So therefore, the SVR as a predictor for the lower recurrent HCC in this kind of the patients. And how about the incidence of the HCC after HCV-Q following interferon or DAA-based therapy? Always discuss for that. And also in the recent and the systemic review and the meta-analysis, and by 44 studies, and to analyze these kind of patients, I mean for advanced fibrosis and cirrhosis patients, you can find after SVR, the people with F3 fibrosis and people with the cirrhosis still have the high incidence rate for carcinoma development. So therefore, we confirm the SVR based on interferon as well as the AA is also important to reduce the HCC development. And another study is for the senior population. This study studied the HCC development by patients age 75 even old after HCV elimination, and by the all DAA treatment. And so in this large-scale multi-center study from Japanese multi-center retrospective study, you can also find the pretty similar data. And here then you can find the patients with the SVR and also with the lower and the FIB-4 score have the low incidence and the low risk for HCC development, and also recurrent, and also for the patients with the AFP provided some information for this kind of the situation. So the question is how to predict and how to stratification for HCC risk in these kind of patients. Because we already know if the patients with the cirrhosis and the advanced fibrosis at baseline, even they achieve HCVR, there are still the HCC risk there. So how to do that? In this study, and they want to use elastography and other fibrosis and score, such as the FIB-4, to do the stratification. Here you can find, and for this advanced chronic liver disease patient, totally is 460 patients, and at the baseline, they test liver stability measurement, and if the patients with the liver stability and the high or equal 12 kilopascal, then the patients will going to do the SVR, also the FIB-4 and the score. If also the FIB-4 is high or equal to 3.7, in these kind of patients, the high risk for the HCC lower development. And so, compared to these kind of patients, if the patient at the baseline is a low liver stability, such as less than 12 paracascal, and also in the second stratification, obtain the SVR, meanwhile, the FIB-4 is less than 3.7, then the patient is low risk. Of course, we have still some patients remain indeterminate risk, and so we showed and focus moderating and surveillance for these high risk and intermediate risk populations. So, how about the low HCC and after SVR, and compare with the before the SVR? So the patients who develop HCC after SVR will have the better overall survival, increasing rates of Q, rate of treatment, increase rate of treatment for recurrence, improve the liver functions. So therefore, and it's important to improve the patient's situation and get OCVR earlier, and then we can increase the cure rate of treatment and better survival for these kind of patients. And so, how about recurrence for this kind of the patients? Recently, there is the meta-analysis that analyzes the proportion of the patients developing hepatocellular carcinoma recurrence following direct acting antiviral treatment. Then you can find, including both the Asia population and the Europe population, Egypt, United States, Australia. And among these of the patients, the finally you can know in the proportion of the patients developing hepatocellular carcinoma recurrent and after the DAA treatment going down. And however, HCV, in fact, if we already achieved the SVR by DAA, still in some risk for HCC and the recurrence risk. So they also analyze this. That you can find in this meta-analysis, DAA treatment and we compare with the low treatment, still reduce the recurrence. So therefore, it seems diagnosis may be late, but treatment level too late. Ladies and gentlemen, I have a summary here. The risk of hepatocellular carcinoma remains in DAA error because of the underlying chronic liver disease, both in patients with and without the history of HCC. And cirrhotic HCV related early stage HCC, DAA improved overall survival due to the reduction of hepatic decompensation. And meanwhile, the recurrence of the HCC after DAA is not negotiable, being higher after end of the treatment, but level too late to treatment. Thank you. Also, welcome to Beijing 2025 March for Apostle.
Okay, thank you very much, Professor Lai. Very nice presentation. He summarizes about de novo liver cancer and also recurrence of liver cancer, both of which are reduced after the DA treatment induced SVR. So he also explains about innovative factors at baseline liver stiffness and also combination with FIB4. Those two factors that stratify the risk of SSC occurrence afterwards. So are there any comments and questions from the audience? Okay, if not, I want to ask you one question. So the categorization of the risk predictor before the DA treatment is really important. So you show the two factors, baseline liver stiffness and also FIB4 index. Have you tried other non-invasive biomarkers for stratification of the risk prediction after DA therapy?
And in addition to the liver stiffness and also FIB4, some biomarkers was used to predict that. And actually, in the one time point at the baseline is not very effective. And however, not very effective study to show us how to use the dynamic change, fibrosis and other score to predict in the long-term HCC development and also for the recurrence. And the question is how to set up the time point and which the cut off for that. But I think you should have the, if you have, and I already know, and in Japan you have many long-term cohort. So therefore, you can do that. And unfortunately, in China, and the HCV patients, if got the treatment, so the patient will, and the compliance is low, and they don't come to the hospital back. So it's difficult to evaluate for that.
Okay, thank you. So you touch on about the importance of metabolic factors for the occurrence of SCC after SVR. And you said that some alcoholics had a higher risk compared to the other non-alcoholics, I think. And have you tried to include some kind of metabolic factors for the prediction of after SVR?
Yeah. And I think in the two study could be in the used to elimination for that. The first one is that in the some study used in the metabolic such as the diabetes and also in pre-diabetes the patients. Even these patients kind of patients are the more easier and higher the risk to develop to the HCC. And another study is the interview, because up to law, you do not have much drug for that metabolic factors. So therefore, and one study used the metformin. The metformin in the patients will have reduced HCC for this kind of the metabolic abnormal patients.
Okay.
So I think maybe in the future, it's also can takes into consideration.
Okay, thank you. And the final question to Professor Rai, and we are in Japan discussing about whether we can treat active SCC patients with DAAs, because some patients, if we treat, as you said, liver function is significantly improved, so which means the next cancer treatment can be available. So such as SVR patients with active SCC. So what do you think about such kind of populations with active DAA treatment?
Oh, it's a good question. And currently, and we have some and how to say that? Actually, still have some challenge for this kind of the patients. So therefore, what you can do, I think, is we give the more communications to persuade and also increase the compliance for these patients to get the treatment. So then you can increase the SVR for this kind of patients.
Okay. All right. Are there any comments? No? Okay. Thank you very much, Professor
Okay.
Rai.
Thank you. Once again,
Okay. We want to invite the next speaker. Next speaker is Professor Wanlong Tran from Taiwan. And his talk is going to be treatment with DAA for cirrhotic patients with or without SCC. Professor, please.
Yes. Thank you, Professor Kondo, for your kind introduction. Good afternoon, Mr. Chairman, dear colleagues. First of all, I would like to thank Professor Sina for inviting me to give a talk. My topic is treatment with DAA for cirrhotic patients with or without hepatocellular carcinoma. I have nothing to declare. Approximately 290,000 people, yes, this one. Hepatitis C virus infection is a major health problem throughout the world. Accordingly to the report by WHO 2023, 58 million people have chronic hepatitis C, and there are 1.5 million new infections each year. Approximately 290,000 people die each year from hepatitis C, mostly from liver cirrhosis and hepatocellular carcinoma. Therefore, the goals for therapy are to prevent transmission, prevent the complication of HCV-related liver and extrahepatic disease, and improve quality of life and remove stigma by cure of HCV infection. The recommendation for testing and treating HCV infection are universal HCC screening, a universal HCV screening, universal DAA treatment, and simplified HCV treatment algorithm for chronic hepatitis C, including compensated cirrhosis. Several DAA were developed to target different processes of HCV life cycle, including NS34 protease inhibitor, NS5A inhibitor, and NSYV polymerase inhibitor. There are few contraindications for DAA treatment, including the use of cytochrome P450 and P-glycoprotein inducing agent, and treatment regimen comprising HCV protease inhibitor that are contraindicated in patients with decompensation cirrhosis and patients with previous episode of decompensation. Sofosbuvir and velpatasvir fixed-dose combination is the first pangenotypic interferon-free regimen for chronic hepatitis C. The result of ESTRA phase 3 program demonstrate that the SVR rate of sofosbuvir and velpatasvir for 12 weeks were from 95 to 100% in patients with HCV infection. The SVR rate of sofosbuvir plus ribavirin for 12 weeks can achieve higher SVR rate than that of sofosbuvir combination in genotype 3 cirrhotic patient. Sofosbuvir plus a protease inhibitor, voxilaprevir, is also a pangenotypic regimen for cirrhotic patients with a SVR rate between 93 to 100%. This slide summarizes the efficacy of sofosbuvir Vox in Polaris phase 3 program. The SVR rate of sofosbuvir Vox for 12 weeks were from 95 to 98% in chronic hepatitis C patients with or without liver cirrhosis. Velpatasvir and pibrentasvir is the third pangenotypic regimen for patients with chronic hepatitis C. The SVR rate was from 99 to 100% just by 8 weeks of GP treatment. The SVR rate of 8-week GP treatment for chronic HCV infection with compensated cirrhosis were between 98 to 100%. The recommended regimen for treatment-naive compensated cirrhotic patients are sofosbuvir 12 weeks and GP for 8 weeks, sofosbuvir Vox and sofosbuvir plus ribavirin 12 weeks are also suggested for genotype 3 infection with compensated cirrhosis and baseline NS5A Y93 race. Velpatasvir and sofosbuvir and abasvir and grazoprevir can also be used in some genotype. The effectiveness of sofosbuvir for compensated cirrhotic patients in a real-world registry data from Taiwan demonstrate a 99% of SVR rate. The effectiveness of GP in a real-world study from Italy shows a SVR rate from 97 to 100%. The GP combination therapy in HCV-related compensated cirrhosis of real-world registry data from Taiwan also confirmed the SVR rate between 98 to 100%. Because the protease inhibitor are contraindicated in patients with decompensated cirrhosis, only sofosbuvir and velpatasvir and sofosbuvir with or without ribavirin can be used. The recommended regimen for treatment-naive decompensated cirrhotic patients are sofosbuvir or soft plus ribavirin 12 weeks and sofosbuvir or soft for 24 weeks. This phase 3 clinical trial demonstrates that treatment with sofosbuvir plus ribavirin achieved 94% of SVR rate in HIV decompensated cirrhotic patients. The real-world data from Japan show that the SVR rate by sofosbuvir and velpatasvir for HCV-related decompensated cirrhosis was 90%, as well as that in the compensated cirrhotic patient. The SVR rate of Sofosbuvir in treatment-experienced patients was 98%, as high as that of treatment-naive patients. GP 12 weeks is also effective in previously treated chronic hepatitis C patients. The SVR rate was around 90%. GP plus SOF was used for retreatment after DAA failure with NS5A resistance. The per protocol SVR rate was 98%. Software with ribavirin for 24 weeks had been tried in previous treatment failure chronic hepatitis C and obtained a 91% of SVR rate. Rescue treatment with multiple targeted therapy, for example, software box, GP, or GP-SOF, with or without ribavirin, was effective in most patients who fail on software box retreatment. Therefore, software box, GP, and GP-SOF with or without ribavirin are recommended in retreatment of DAA treatment failure compensated cirrhotic patient. The real-world study to treat chronic hepatitis C patient with DAA failure by using the software box, showing an excellent result of 95% SVR rate. HCV genotype 3 liver cirrhosis and active HCC were independently associated with failure of software box retreatment. For hepatitis C related cirrhotic patient in liver transplantation setting, no main score patient without HCC or index complications should be treated immediately. Metal score less than 18 should be treated before transplant. Patients with MEL score greater than 20 may be better served by transplantation. However, if the waiting time is greater than 6 months, patients should be treated first. The recommended regimen for treatment-experienced decompensated cirrhosis are software or SOF plus ribavirin for 24 weeks. The SVR rate by DAA in hepatitis C patients with active HCC were lower than that in patients with inactive HCC in this multi-center real-world registry study. In the Taiwan HCV registry program, the SVR rate in patients with inactive HCC was also lower than that in patients without HCC. The ESO practice guideline recommends that patients with compensated cirrhosis and HCC who are eligible for curative therapy should defer DAA treatment. So we must treat the active HCC patient with curative therapy before DAA treatment. Patients with complete response to HCC therapy should be treated for HCV infection. Patients palliated for HCC may be treated for HCV depending on the overall prognosis and potential benefit. In the interferon era, the SVR by interferon-based therapy can reduce 90% of HCC occurrence in chronic hepatitis C patients, but the SVR can only decrease 50% of HCC occurrence in patients with liver cirrhosis. DAA-based therapy could improve the major HCV-related outcome. The HCC incidence rate only decreased 43%. In this multi-center study from real C cohort, the incidence rate of HCC occurrence was significantly lower in the SVR group of HCV-related cirrhotic patient, and the 5-year cumulative incidence of HCC occurrence decreased 68% in the SVR rate. The real-world data from Taiwan show that the cumulative incidence of HCC in cirrhotic patients treated with DAA declined 48% in patients with SVR. This prospective long-term follow-up study from Italy demonstrates high cumulative incidence of HCC occurrence after SVR in HCV-related cirrhotic patients and patients with previous HCC. So the de novo and recurrence of HCC were still high even after the patient achieved SVR post-DAA treatment. Therefore, patients with high risk for HCC, for example, older age, low platelet count, cirrhosis, excessive alcohol drinking, obesity, and diabetes, should undergo surveillance for HCC every 6 months. Post-SVR HCC surveillance by means of ultrasound every 6 months was suggested by ESO. Surveillance using imaging and serum tumor markers is recommended by AASLD. In summary, dear colleagues, the goal of antiviral treatment for HCV-related cirrhosis is to suppress progression to liver failure and HCC, and to improve prognosis by HCV eradication. Simplified treatment with pan-genotypic regimen should be used in patients with compensated cirrhosis. The recommended regimen for treatment-naive compensated cirrhotic patients are software 12 weeks and GP for 8 weeks. Protease inhibitor-containing regimens are contraindicated in patients with decompensated cirrhosis. The recommended regimen for treatment-naive decompensated cirrhotic patients are software or lead-soft plus rioirin for 12 weeks and software or lead-soft for 24 weeks. Rescue treatment with multiple targeted therapy, for example, software Vox, GP, and GP soft with or without rioirin are recommended for the treatment of DAA treatment failure compensated cirrhotic patient. The recommended regimen for treatment experienced patient with the recommended regimen for treatment experienced decompensated cirrhosis patient was software and lead-soft plus rioirin for 24 weeks. Patients with compensated cirrhosis and HCC who are eligible for curative therapy should defer DAA treatment. Patients with complete response to HCC therapy should be treated for HCV infection. Patients palliated for HCC may be treated for HCV. Cirrhotic patients with SVR should undergo surveillance for HCC every 6 months by imaging and serum tumor markers. Thank you for your attention.
Thank you very much, Professor Chan, and have a very nice presentation covering the current efficacy of DAA therapy according to the various populations of HCV infection, and also importance of inducing SVR again for the reduction of SSC occurrence after attaining the SVR. So are there any comments? Okay, please.
Thank you for your nice presentation. My name is Morimoto from Kanagawa. And my question is, you showed that patients should be treated with HCC, but HCC after curative treatments. So recently, some chemotherapy achieved CR, even in stage BCLC. And do you think that DA is better to use stage C patient after curative treatment?
Yes, of course. Thank you for your kind question. In fact, every patient should be treated unless their lifespan is less than 1 year. So we choose to treat the patient with active HCC is because the active HCC will impact the SVR rate of the patient. So after curative treatment, we can perform HCV treatment. But for the patient receive systemic therapy, perhaps they can achieve complete response, even partial response. We must treat with HCV because the HCV infection will induce liver functional damage. So if we treat the patient with HCC, we may prolong their survival. But even the SVR rate decrease, but we can retreat with multiple target therapy. For example, Sofia-Vox or GP plus or even with Rivaroxaban, we can still achieve more than 90% of SVR rate. So we must treat every patient. I just mentioned because if the patient can be treated completely for active HCC, we can treat initially, then treat HCC initially, then treat the HCV infection.
Thank you. I think so too. Thank you very much.
Thank you.
So, Professor Strong, that means if the tumor condition is better and that is diagnosed the curative, that tumor, so initially start the curative treatment for SCC. Then right after that, you start the DA therapy. Is that correct?
Yes.
In your country?
Because we can perform the operation or local operation therapy. For example, RFA, microwave, or even use PEI. Then we treat the HCV infection.
Okay. Yeah. All right. Okay, please.
Hi, thank you very much for your talk. I'm Rose Karamatic from Townsville, Australia. My question is almost along that line. It's about timing of DAA therapy in the context of immunotherapy. So theoretically, there could be a risk of reactivation of Hep C with treatment. So would you consider starting treatment at the same time, Hep C and immunotherapy?
Yeah, I think because the treatment, even with DAA, we still have drug-drug interaction. So if we treat the patient with HCC, perhaps we can try to treat. If the patient can be treated by curative therapy, then just waiting for 6 months or 1 year is okay for the patient with HCV infection, but you can obtain much higher SVR rate.
I think the problem with those other groups of patients, they don't have that luxury of time to wait.
Yes.
So I guess the theory, maybe there's drug interaction, but there's no data. But I have one patient where they did have treatment with immunotherapy and got Hep C nephritis. So my theory is that maybe that was because of an effect of the PD-1 on the Hep C, but I don't know, and I don't know if anyone else knows of any data along that line. That's why I asked the question.
In fact, we have performed a retrospective study to find whether the patient received DAA treatment during their HCC treatment, we found that even the SVR rate did not be influenced, but the survival of the overall patient is prolonged. So even with a patient with partial treatment or under treatment, we can still perform the DAA treatment, and we can prolong the patient's survival. Yes.
Agree. Actually, just as a quick second question, if I may, do you have any comments about SVR4 in the two common regimens? Well, in Australia, we have Epclusa and Mavorite. What are your thoughts on using those parameters instead of SVR12?
Pardon?
They're using the 4-week SVR instead of 12-week SVR.
Yes, I understand. In fact, we already published the concordance of SVR4 and SVR12. The concordance rate is more than 95%, but because Taiwan is the DAA treatment is covered by the national insurance, we must obtain the SVR12, and then the government will pay the DAA treatment. So we always follow the patient until SVR12. In fact, I understand if the patient did not relapse at 4 weeks post-treatment, they should have SVR.
Is that with sofosbuvir and velpatasvir combination?
Yeah, we use SVR12.
Okay.
Yes.
Thank you.
Thank you.
Okay, very nice, good discussion. And is software box approved in your country?
Yes.
Yes. And usually the software box used for relapse cases.
Yes, for relapse patient.
Okay. What's the percentage of SVR induction for the relapsers with SVR?
Because treatment failure is about 1 to 2% in Taiwan, analyzed by the whole country data. So only small patients were treated, or small number of the patients were treated with software box. And the response rate is quite high, more than 90%.
Okay, I got it. Thank you. Okay, if not, okay, thank you very much, Professor Chuan.
Thank you very much.
Okay, so the next speaker is the final speaker in this session. So Professor Asukawa, you have plenty of time because you have double time if you want. But anyway, here's a professor from Nihon Medical School Hospital, and his title is Morphological changes in esophageal varices in cirrhotic patients who achieved SVR. Please.
Thank you. Introduce me, Professor Kanto. I am Masanori Asuka from Nippon Medical School, Japan. And thank you for giving me the opportunity to give a presentation today. I'd like to talk about the clinical result of treatment with DAA, including GP and software in cirrhotic patients, especially morphological change in esophageal varices in cirrhotic patients who achieved SVR. And I apologize, my title is not much the theme of this session. This slide shows my COI. Here is a member of the KTK49 reverse study group. I'd like to report the result of treatment on behalf of this group. This is a guideline for hepatitis C treatment in Japan. Today, I will mainly discuss of GP treatment for compensated cirrhosis and software treatment for decompensated cirrhosis. This is a GP or no. Today I will tell you about the real-world clinical treatment result of GP. So far, our group has reported several papers on GP treatment, such as 8 weeks regimen and 12 weeks regimen and GP for CKD patient. So I'd like to tell you the result of the integrated analysis. This table shows the background of 1,439 patients. These patients included 408 with cirrhosis, 20 genotype 3 patients, 219 previously treated with interferon D regimens. These graphs show the result of sub-analysis. High SVR rate were achieved in all categories such as cirrhosis, DA experienced, and genotype 1 and 2, and CKD or CKD stages. On the other hand, 4 of the genotype 3 patients failed to achieve SVR. So to clarify the influence of these factors on treatment result, we investigated the factors associated with non-SVR. Multivariate analysis identified HCV genotype 3 infection and past experience of DA as significant independent factors associated with non-SVR. Previous HCC status was not extracted as an independent factor associated with non-SVR. This is short summary 1. GP regimen is highly effective even though patients with refractory factors such as compensated cirrhosis and past treatment of HCC and CKDs. Next, let's move on to software treatment in patients with decompensated cirrhosis. Our group also reported on the efficacy and the safety of software treatment for decompensated cirrhosis. I'm pleased to present a detail of this report. This slide shows the 71 patients' background. The median Child-Pugh score is 8 and the maximum was 13. In Japanese phase 3 trial, the cohort was up to 12. Instantly, patients with a score of 13 achieved SVR. In addition, many patients with a history of hepatocellular carcinoma entered the study, reflecting the real-world clinical data. We also observed many cases of barrix prior to DA treatment. First, this graph shows the efficacy of software treatment with 2 cases of relapse and death that was not causally related to the drug under treatment. As a result, 4 cases of non-SVR were observed, and the SVR rate was approximately 94% in ITT. Next, these graphs show the result of sub-analysis. There was no difference between the group in comparison in terms of liver functional reserve or in the presence or absence of prior HCC. This slide shows the barrix condition before treatment and the barrix change afterwards. Unfortunately, barrix rupture was observed in 2 cases during treatment. Both of these cases were F2 or F3 and should have been treated with EIS or other treatment prior to DA treatment. Here is a slide showing how liver functional reserve changed after achieving SVR. 4 child C cases improved to B and 2 to A. Of the 47B cases, 70 became child A. 1/3 of all cases showed improvement in Child-Pugh grade. And the next topic concerns the reduce risk of developing HCC with DA treatment in decompensated cirrhosis. As you can see from previous report, achieving SVR suppressed the incidence of HCC to some extent, even in decompensated cirrhosis. Therefore, we investigated the outcome of patients who developed HCC after achieving SVR in our cohort. For the bottom case, the pre-treatment hepatic functional reserve was very poor. Marby score was 3. And however, a slight improvement in hepatic functional reserve after achieving SVR made it possible to introduce subsequent systemic chemotherapy. This is short summary 2. Achievement of SVR with software improved the liver functional reserve at 12 weeks post-treatment. I believe that development of HCC and the point of no return after achieving SVR are the remaining issues in the current hepatitis C. Today, I'd like to discuss the point of no return after achieving SVR. According to the previous report, patients who had difficulty in reducing portal vein pressure after achieving SVR with DAA was a high portal pressure or poor hepatic functional reserve at the baseline. Furthermore, although this is a paper from interferon era, it has been reported that achieving SVR does not change the diameter of the already established collateral formation. So they evaluate the change in the collateral formation in the DA era, and they reported that the characteristic of patient with varices aggravation are low platelet count and high LSM. According to another report, the characteristic of patient with varices aggravation are LSM 25 kilopascal at baseline and LSM 20 kilopascal or more after achieving SVR. This result similarly showed the importance of measuring LSM as patients with advanced fibrosis should be noted for varices aggravation. So therefore, we investigated the change in the characteristic of esophageal varices before and after DA treatment in patients with liver cirrhosis, including decompensated cirrhosis. The following patients were defined as esophageal varices aggravation. 1, factor F worsened after treatment. 2, RC increased from -2 plus after the end of treatment. 3, EIS or EVL was performed due to varices aggravation. This table shows the background of this study, including 171 patients with compensated cirrhosis and 72 patients with decompensated cirrhosis. Child A, B, C were 163, 68, and 12 respectively. And 155 patients had no varices, 59 patients had F1, 25 patients had F2, and 4 patients had F3. This slide shows the morphological change of varices. During the 2-year follow-up period, 11.9% of patients showed improvement of F factor. 73.3% remained unchanged, and 14.8% deteriorated despite of achieving SVR. We analyzed the factors associated with varices aggravation. As a result, RB score at SVR 12 was extracted as a significant independent factor associated with varices aggravation. ROC curve analysis revealed the optimal cutoff value of 2.33 for RV score at SBR12 in predicting Barrick's aggravation. The aggravation rate was significantly higher in patients with RV score less than -2.33 compared to those with RV score more than -2.33. Here is the cumulative incidence rate of post-SBR Barrick's aggravation. The cumulative incidence rate of Barrick's aggravation were 7.5, 16.3, and 17.9% at 1, 3, and 5 years after achieving SBR respectively. They were significantly higher in patients with RV score at SBR 12 or more than -2.33 than in those with RV score at SBR 12 less than -2.33. Next, among 155 patients without Barrick's at baseline, 70 patients showed de novo post-SBR esophageal Barrick's varices. We also analyzed the factors associated with de novo post-SBR esophageal varices. As well as Barrick's aggravation, high RV score at SBR 12 was extracted as an independent factor. This means that patients with poor hepatic functional reserve are more likely to develop de novo post-SBR esophageal varices, even if there was no Barrick's before treatment. ROC curve analysis revealed the optimal cutoff value of -2.65 for RV score in predicting de novo post-SBR esophageal varices. The de novo post-SBR esophageal varices rate was significantly higher in patients with RV score at SBR 12, less than -2.65 compared to those with RV score at SBR 12, more than -2.65. Here is a cumulative incidence of de novo or post-SBR esophageal varices. The cumulative incidence rate of de novo post-SBR esophageal varices were 0%, 6.7%, and 70.7% at 1, 3, and 5 years after achieving SBR. They were significantly higher in patients with RV score more than -2.56 than in those with RV score at SBR 12 or less than -2.65. In 88 patients of 243, LSM was measured before DA treatment. The median baseline LSM in patients with Barrick's aggravation was significantly higher than that in patients without. The optimal cutoff value for baseline LSM was 14.3 kilopascal to predict post-SBR Barrick's aggravation. The aggravation rate was significantly lower in patients with baseline LSM less than 14.3 kilopascal than in those with baseline LSM more than 14.3. This slide shows summary 2. Patients with cirrhosis can experience Barrick's aggravation despite achieving SBR with DAA. In particular, patients with high RV score at SBR 12 had a high likelihood of developing esophageal Barrick's aggravation and de novo esophageal varices, even for a long period after SBR, and should undergo EDD. To sum up, GP was highly effective in genotype 1 to 2 chronic hepatitis C patients with compensated cirrhosis. Software treatment for decompensated liver cirrhosis is highly effective and improves liver functional reserve in some patients after achieving SBR. Some patients with cirrhosis can have de novo or aggravated esophageal varices even after achieving SBR with DA treatment. Here is a list of the members of the Morris Center study group. I present our data on behalf of this group. Thank you.
Oh, thank you very much, Professor Atsukawa. Very nice story regarding about the aggravation of esophageal varices. Even the patients who are going to be the SVR. That's really impressive data. Okay, are there any comments from the audience or questions? Welcome. So, Professor Atsukawa, let me start from me. And I'm really impressed about the de novo aggravation or de novo emergence of esophageal varices, even the patients with SVR. And you show the cutoff by the RB score. Is that the all SVR 12 point or not before starting the therapy?
Thank you for your question, Professor Kanto. We analyze the factor associated with post-de novo SVR varices aggravation or de novo occurrence. But the baseline LSM or platelet count or RB score at baseline does not identify the factors associated with aggravation or de novo SVR varices.
All the factors you analyzed was a point of SVR 12.
Yes.
Okay. So that means if the patients are the liver function reserve improved by the DAA treatment, so the risk of aggravation or of course de novo emergence of varices are significantly reduced. Am I right?
Thank you for your question. Basically, the patient whose liver functional reserve improved were low risk for development of esophageal varices. So personally, patient whose liver functional reserve did not improve or low platelet count and high LSM at baseline should be monitored even after achievement SVR.
Okay, so that's really important message to the clinicians. So if we see the patients with high liver function, I would say child class B and no varices. So what should we do after achieving the SVR? So extensive monitoring by the gastrofibroscope or some other way to more accurate predict the occurrence or aggravation of esophageal varices.
So child B?
Yes, child B or B without the slight varices.
Child B and no varices at baseline.
Yes, yes. Not so many, but still there are, I think.
According to regarding at baseline score, I don't think he or she do not receive EGD, but after treatment of DAA, the liver functional did not improve. I recommend to receive EGD.
Okay. If the varices are aggravated, maybe you can treat them by the EVR or the other ways. So how such kind of patients after the treatment, the recurrence rate, is that dependent on also the liver function reserve or some other factors might be involved?
Thank you for
after
your question.
Achieving the SVR.
Unfortunately, I don't have the information right now, but it's important issue, so I will analyze that.
Okay. Okay, so are there any questions or comments? Professor Hosaka? No question? Okay. All right, if not, we have 15 minutes remaining in the session, but okay, thank you very much, Professor Atsukawa.
Thank you.
Okay, so thank you very much for the attendance. I want to close this session.
Thank you very much for the lectures and Dr. Kanto.